We'll start with roll call, please.
Senator Rocky Adams, Senator Alvarado,
Here.
Senator Berg, Representative Bentley, Representative Herron, Representative Mosier, Co-Chair Meredith,
Present.
Co-Chair Meade.
So note that we do have a quorum. This is the fifth meeting of our CHFS Organizational Structure, Operations, and Administration Task Force. I know I get a little ahead of myself, but we will have one more meeting on November 2nd and possibly one other after that, depending on what kind of progress we make in the next two meetings, today included. With that, they got a lot of material to cover. Let's get right into the agenda. Is there a motion to approve the minutes of a September 21st, 2022 meeting? Motion by Representative Bentley, seconded by Senator Alvarado. All those in favor say aye. Any opposition, by like sign. There being none, the minutes pass. Jumping right into our presentations, our Kentucky Department of Behavioral Health, Developmental, and Intellectual Disabilities. I see that you're all here and present. If you would, you know the routine. Identify yourself for the record and feel free to proceed.
Thank you. Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
Wendy Morris, Commissioner for the Department of Behavioral Health, Developmental, and Intellectual Disabilities.
And Stephanie Craig-Craft, Deputy Commissioner.
Please make sure your mics are on so that we can
Yeah.
hear everyone.
There we go. Yes, I was acting over this department for about 6 months while in between commissioners and learned a lot. I do like to joke about some of that, but each time and each stop at a department, I learned something. And with behavioral health, I learned something, lots of valuable
So do we, as a
things
matter
there.
of fact.
Yeah. So I think one of the biggest things, and I'll tell you a quick story and then move on because I like to tell stories. When I went to the Department for Behavioral Health, I come from the Commission for Children with Special Health Care Needs, previous to that. And so we were doing a commissioner search. And I wanted to make sure I had everybody who was involved in that as a part of it. So I had I had parents. And I got a ton of grief because the people with behavioral health issues who were adults said, our parents don't speak for us anymore. And it was one of those nothing about us without us moments, and where I was trying to do, or I thought I was trying to do the right thing, where I got an education pretty quick on people that I've been leaving out and left out unintentionally. But it was a great education for me. As you all know, behavioral health is really, and substance use. This department is probably going to have and will have over the next several years some tremendous challenges as we look at what has happened with substance use disorder, overdose deaths in Kentucky. Really been on the front lines with making some progress, and then really we've seen some real declines last couple of years. I talk about COVID as being the perfect storm of isolation and economic uncertainty and having those questions and worried about where you're going as being a perfect storm, and not having necessarily ready access to treatments and services as being a perfect storm for kicking the opioid addiction overdose back up, which is what we have seen. Attended last night with Representative Moser, Attorney General's listening session in Northern Kentucky. It was also very educational. I was saying to this group beforehand, there was a discussion at the EMS task force about some of the issues that we heard about transportation, and what happens with EMS and where they actually send folks, and how hospitals do a warm handoff for folks with substance use disorder, and some of the collaboration that Representative Moser, you of course sponsored in Northern Kentucky and had a lot to do with. So I hope you felt affirmed in all you had done up there. Yeah. So I want to say thank you for that. Also, then behavioral health. And you all have seen this, right? Behavioral health in schools, which we've seen the challenges there. Behavioral health in general. Those are challenges that we have as a state. When we look at Medicaid and we look at the highest prescribed medication in Medicaid, it's antidepressants. So we've got a lot of work to do in Kentucky, and no pressure, but let me introduce to you the Commissioner of Behavioral Health.
Good afternoon. Thank you. So we're just going to give an overview of our department and then entertain any questions you might have. So first, well, wrong direction.
You could put your mic a little bit closer to you, please.
Sure. Is that better?
Yes, thank you.
All right, great.
Sorry.
Okay.
There you go.
All right. So start with our vision and mission, which we did recently update. So our vision is that all Kentuckians are going to have access to quality services and supports to live full and healthy lives. Our mission to promote health and well-being by facilitating recovery for people whose lives have been affected by mental illness, substance abuse, supporting people with intellectual other developmental disabilities, and building resilience for all. A little bit about our responsibility and authority. We are designated as Kentucky's Mental Health, Substance Use Treatment Prevention, and Developmental Intellectual Disability Authority. We're responsible for the administration of both state and federally funded mental health, substance use disorder, and developmental intellectual disability programs and services throughout the Commonwealth. We provide funding, services, technical assistance, and oversight to facilities and community-based programs across the continuum of care and throughout the Commonwealth. And then we also consult and collaborate across systems using our collective expertise. Just some examples of places we collaborate. Of course, we collaborate a lot within our cabinet, the Office of the Secretary, Public Health, Medicaid, DCBS, DAIL, all of the major and minor departments there at the department. And then we also collaborate with a host of other state agencies. These are just some examples: Office of Drug Control Policy, Department of Corrections, the Kentucky Emergency Management, especially during the recent disasters, the Kentucky Department of Veterans Affairs, AOC, Department of Public Advocacy, Department of Education. So we are involved in all kinds of things. This is our map. I think I show this literally every time I come over. No updates, it's the same map, but again, it kind of shows all of our hospitals, ICF, specialty clinics, all the different services we have, and then it breaks with those large black lines into the 14 community mental health centers. On any given day, we have about 800 individuals in all of our facilities combined, and this system overall is the public behavioral health safety net. So this just shows the organizational structure. So we now have 5 divisions. So the Division of Mental Health and Substance Use, and we did, as you know, recently divide those. It used to be the Division of Behavioral Health, and that's because there's so much more going on with substance use and quite frankly, a lot more going on with mental health now that we just didn't have the capacity to really do that all in one division. So we've teased that out. Then we have the traditional AFM, our Developmental and Intellectual Disabilities Division, and then our Division of Program Integrity. So we have 3 clinical divisions and 2 support divisions. The Office of Autism is attached to us administratively. They're at the top, and then we have a host of facilities. ARH looks a little different on here because it's a facility that we don't own, but we do operate it. They are a state-designated hospital that we have a contract with them. So all told, we employ about 1,300 state and contract facilities, and then there's additional 1,400 staff that are employed in our contracted facilities.
So the department's FY23 budget, the slide shows, is $530.9 million. The largest portion of that budget, $299.7 million, 56%. is for our residential. That's for our facilities, our psychiatric hospitals, ICFs, and nursing facilities. 21%, $110.2 million, supports community-based programs that provide substance use prevention and treatment services. 16%, $82.7 million, provides for community-based mental health programs. 16% or 5%, $29.2 million, is for community-based programs for individuals with intellectual and developmental disabilities, and then 2% is for general support. The next slide shows our budget by fund source. Of the $530.9 million, $228.1 million, 43% are agency funds, and those are primarily receipts from the operation of our facilities, Medicaid, Medicare, and other third-party payors, probably about 210 million of that. And then 33%, 177.8 million is general fund. 7.7 million, 2% is tobacco settlement funds. And those are for programs for pregnant and parenting women with substance use disorder. And then 117.3 million, 22% are federal grant funds. The largest part of those, our largest grant is our state opioid response effort grant, 36 million. Our SAPT block grants around 20.5 million, and our community mental health services block grants about 10.7. Those are our larger grants. And then, in addition to the larger grants, the
And
department.
may I just for 1 second? That agency fund, that is really almost all Medicaid. That's all. When we talk about agency funds in the Cabinet for Health and Family Services, I think I've said earlier on different departments that agency fund is, and particularly in behavioral health, a lot of that is Medicaid, vast majority.
Yeah, it's probably about 160 to 170 million each year for Medicaid. All right. In addition to those larger recurring grants, the department's fairly successful at securing competitive grants, primarily through the Substance Abuse and Mental Health Services Administration. So this slide just provides a list of some of the competitive grants that we have applied for over the past several years and been awarded. On an annual basis, these would be approximately $17 million.
All right. So the next couple slides just go through some of our clinical divisions. This, again, is a division of mental health. It's a new graphic, and I think it just is a good representation of just how diverse the services that we offer for adults, for children, school-based services, deaf and hard of hearing services. We do our emergency services, our promotion, prevention, homeless services, just all types of things. So again, we work for those outpatient services primarily with the community mental health centers, who provided services to over 146,000 individuals with mental illness, including 44,000 adults with serious and persistent mental illness, over 12,000 children with serious emotional disability, and then we answered somewhere between 2,000 and 2,500 988 crisis center calls per month. And again, that number was changed to 988 this summer, but it was the lifeline previous, and we've been building that system for 15 years. Next is our division of substance use disorder. Again, it's very complex, and we do prevention, promotion, treatment, housing, just all types of peer support, all types of things here. And in fiscal year 22, the CMHC's reported they served over 24,000 individuals who were diagnosed with substance use disorder who got outpatient therapy, 2,600 unduplicated individuals who received short-term residential services, 844 who got long-term residential services, 6,700 adults who received substance use disorder peer support services. And then some additional things would be, there were about 33 million doses of prevention. And this bucket would include would be disseminate information such as community events, media campaigns, community-based programs. Again, those would be meetings or trainings, education such as school curricula like Too Good for Drugs or youth mental health first aid for school personnel and other folks who work with youth, problem identification and referral. And this is a place, to Secretary Freelander's point, where our numbers have really increased substantially due, in part due to the expansion of substance use prevention media campaigns, but because we just know kids are really struggling right now. This next slide is on our opioid response effort. Again, prevention of initiation and misuse, early intervention, treatment, access and retention, and sustain and recovery. So you can see there's numbers in each one of these boxes focusing on some youth primary prevention. We've got a number of hospitals committed to opioid stewardship, doing lots of screening and assessment work, lots of over 14,000 opioid use disorder treatment services, 55 core funded peers were hired statewide, and 9,500 folks received recovery support. And then for harm reduction, which we do in collaboration with public health, almost 7,000 suspected overdoses were reversed. And then we continue to build personal, family, and community capital with the coordination of almost 250 programs statewide. Our last clinical division is for the Division of Developmental and Intellectual Disabilities. This is where our department administers the Supports for Community Living, or SCL waiver, and the Michelle P. waiver for Medicaid. Supports over 15,000 people to live in the community. We provide technical assistance, administer functional assessments, collaborate with and monitor the 14 community mental health centers who serve more than 16,000 folks with IDD every year. We oversee the crisis program to support folks with IDD, with over 1,600 crisis contacts made in 2021. And then we review and complete follow-up for an average of 1,400 critical incidents every month. Again, the Office of Autism is administratively attached to our department, and Tal Curry, who oversees that, does participate in all our leadership meetings. The mission there is to promote collaborative efforts and advocates to improve systems of supports for individuals with autism, and their vision is that individuals with autism of all ages are engaged in self-determined lives and are valued citizens of the community. So they provide a communication network between state agencies, work to improve the coordination of resources, provide administrative support to the Kentucky Advisory Council on Autism, and support the 28-member Advisory Council. So these are just some other areas, I guess, for collaboration where we have a seat and where we interact, again, with folks not just from across our cabinet, but across other agencies. So SEAC, Juvenile Justice Oversight Committee, House Bill 144, which is folks with IDD. We've got the Eating Disorder Council, Kentucky Suicide Prevention Group, Center for School Safety Board, the Core State Implementation Team, Opioid Abatement Task Force, et cetera. So just lots of ways that we work with other folks. This just lists our key priorities for this year. So number one is to continue to increase access to behavioral health and intellectual disability supports and services. Second is to improve the quality of that care in that system. And third is to reinforce a resilient, inclusive, and equitable organizational culture. And those are our slides.
Thank you. I'm sure we'll have questions. We will entertain those. If you would, let me start it off. I've got 40 years of working in healthcare, but I've never professed to be a healthcare professional. I'm a businessman who just happens to be in the administration of healthcare, so I view things from a very different perspective than some people do. And one of the things that comes to mind to me on your slides is regard to how substance abuse fits into behavioral health and development and intellectual disabilities. It's like apples and pears to me, and I'm not sure that that's the best fit. But who made the decision? Because I think it's a public health issue.
Well, first, the term behavioral health means mental health and substance use disorders. So that term behavioral health is collective of those. And not all states have behavioral health and IDD together, but we address the behaviors across all of that realm.
I think that's one of my concerns, is particularly with substance abuse, is how do you measure success in your efforts?
Sure. Well, I mean, one of those is overdoses. One of those is recovery, sustainability, employment. There's lots of ways. There's also so much co-occurring, right? A lot of folks have substance-induced mental illnesses, so depression and anxiety often can come when you have a substance use disorder. And then there's folks with primary mental illness who self-medicate with substances to, mitigate their hallucinations or paranoia or other symptoms that they have. So it's almost impossible to pull those apart.
I don't know that I agree with that. Again, this is probably the most significant public health challenge that we have, and it just seems to me to be a better fit with Department of Public Health in
And
your
we do
division.
partner very closely with them on harm reduction. So with things like syringe programs and getting Narcan out and those types of things, we're a close partnership. And I know Department of Public Health follows us and will likely speak to that as well.
Well, I think that's one that we may have to explore. But Senator Alvarado, you have a question?
Yeah, thank you, Mr. Chairman. It's to that point. Right now I think we've got Office for Drug Control Policy has some say in this. Department of Public Health, OIG, all of them. You guys on your third slide there, I think you call yourselves the authority on this issue. So we've got at least 4 different agencies that are kind of working on drug policy, and we're tasked here to try to find ways to kind of eliminate redundancy and try to be more efficient with this. And we have 4 different departments outside of the cabinet, out in justice as well, that handles a lot of this. And so that becomes the question is, should this be scattered through 4 different departments all working together, or should it be under one department where everything is handled on this topic and this issue? And I know there's different varied outside issues about these things. I mean, there's legal side of this, there's treatment side of this, prevention, all those things. There's mental health issues with all this. But that's what we're trying to figure out, I think, is if you guys are labeling themselves the authority on this topic, and I get it, would be better to put this all underneath one kind of umbrella when it comes to this topic instead of scattered through several different ones. And I'd like to get your take on that.
Well, I mean, I would say we probably have the biggest role in it because we do not just prevention and harm reduction, we do treatment and the whole realm. And right now the block grant dollars come to our department, the opioid abatement funds come to us, or rather the core funding from the federal government. So those come to us. We do collaborate closely. Go ahead.
I was just going to add, and we do collaborate closely with the Office of Drug Control Policy. So they do receive funding statutorily for treatment services through the community mental health centers and for services to address neonatal abstinence syndrome. And they come to us to administer those funds. So we work really closely with them. That was a choice made on their part that we were the treatment and recovery experts and that they wanted us to do that piece. So some of those agency funds that are in our budget are actually funds that come to us from the Office of Drug Control Policy that then we work to get out to providers.
But we can certainly see your point. We think it's where it needs to live. Again, showing my long time in the cabinet, I remember when it was everything was under a public health banner, right? Everything was under the public health banner, and it was decided that, this is my memory, that because it all sat under public health, like the behavioral health side wasn't getting, and that did include substance use, was not getting the attention that it needed. I think it's the call of this committee, right? The charge of this committee to look at what is the best arrangement. And so I think, there can be a variety of opinions and a variety of how you might set it up from an organizational structure. Absolutely. And I just, at this point, I know that the professionals within the Department for Behavioral Health, you all probably know, Dr. Brenzel, Dr. Marks, really have done a tremendous job in doing some leadership through the core pieces. And we've seen additional challenges. There's no question around that.
Well, just trying to gather up, figure out if we're going to restructure this, where would it fit best to coordinate. I know there's different aspects of it. Everybody's got their own specialty underneath that, but it's just trying to find a way to reduce redundancies on that. Another question I had was also on our SCL Michelle P. waiver kind of programs. So what's your role when it comes to those waivers, I suppose, within your
Right.
department?
So our division oversees that waiver. So we provide oversight of the providers, do in-home visits, and cite them when we need to, provide technical assistance, provided lots of support during the disasters, during COVID to make sure folks were okay. And we communicate regularly with Medicaid about those types of things. So I don't know if that answers your
Yes,
question completely.
some of the things I had written down here in my notes. So you administer these programs on behalf of Medicaid, correct?
Correct. So they're the payer, and we are like the clinical. We provide the clinical oversight, I guess.
You guys get funding
Yes.
From your department
From
for
Medicaid,
for
yes.
Medicaid for that. Do you guys set the policies for these waivers?
We follow the regulations for the waivers.
Okay, so you follow, but do you set the policies themselves, or is that done
We-
through?
We have some standard operating procedures, but we follow the regulations.
Okay, so
Was your question, they collaborate on policies with Medicaid? I think
Yes.
the very first committee meeting, I think you all asked me, where's the best place for the waivers? And I
Yeah.
put my hands to my head.
right. Well, that's what I'm getting at too
Yeah,
here. Is
right,
effectively,
yeah.
that is, how does the cabinet kind of reconcile Medicaid-funded programs being administered by a completely different department with a different commissioner and leadership staff and all those sorts of things? And could the expertise that exists really within your guys' department to administer these programs be relocated to Medicaid or not? So again, it's just I'm trying to find a way to reduce redundancies, and it's to that point is where's the best place for some of those? I mean, we've had members from health and welfare who are very passionate about those waivers, obviously, and a lot of us try to keep finding funding, and it's always a topic of conversation every year. But it's just trying to figure out the best place for that, and that's kind of where I'm getting at with those questions as well. I don't know if anybody has the answer per se, but
I don't think there is
all right.
one.
Thank you, Mr. Chairman.
Thank
Oh,
you.
may I go back to one on? This is just history, okay? So 2 history points because I'm old. One is the first one is until probably about 5, 6, 7 years ago, for a community mental health center to treat substance use, there had to be a mental health diagnosis, behavioral health diagnosis, mental health diagnosis. Sorry. Again, I'm old. I'll just there had to be a diagnosis before you could treat the substance use, and we were forcing a lot of the community mental health centers to come up with a behavioral health diagnosis before somebody could get the substance use treatment. Again, probably a reason why, particularly historically, it resided within the Department for Behavioral Health. That changed several years ago, and that's a good change. But that's a history piece. Go ahead.
Well, I was going to say, we also, for instance, in our state psychiatric hospitals, we have dual diagnosis units because people, like I said, the co-occurring with the mental health and the substance use is so common.
And the other piece to your waiver question, again, this is a long time ago when Mark Birdwhistle was in Medicaid and I was in the Inspector General's office. It was about who was going to regulate the providers. And so I've been around long enough that some of the decisions I helped create have come back to bite me. So my job going from the Inspector General's office and negotiating with Mark Birdwhistle was to make sure that the Inspector General's office didn't do the regulating and it ended up in behavioral health. And that's the whole story of why that happened.
Representative Bentley.
Thank you, Mr. Chairman. I have one question for information. The governor is up in Prestonsburg with a new autism center. Did that go through your all's okay, or how did that get established?
I would have to ask the person who's over our Office of Autism. I don't know.
Well, that's under you, though, isn't it?
It's administratively attached to me,
Okay.
yes.
Okay. I just wondered because they hit us with that news notice today. He was there at Prestonsburg. My question is, this summer in the interim, we had in Health and Family Services, and this is to you, Secretary, the last session I sponsored House Bill 349 on CMHCs, the regional legislation. During that testimony this summer at the interim Health and Welfare and Family Services Committee, the regional bill was discussed, and I remember one senator asked me directly, some members asked, does the Cabinet and Secretary Freelander support the legislation? Does the Cabinet support the legislation? Yeah.
So this is the one around the types of services that a CMHC can provide inside and outside of their region. Is that right?
Right.
Okay. So
Based upon President Kennedy's law.
yeah. So the Eric, I'm going to refer to you again. We at the time those regions were defined, and you really couldn't provide services outside your region. Decision was made, and I would have made the exact same one, that competition's good. Let's let folks provide services outside their region. Let's make sure that we're getting enough services across Kentucky as we need. The nuance to that, and I think it was a part of your bill that I now fully support, is that if a center is going to provide services outside of their region, they should probably be licensed as a behavioral health services organization and provide under that license. The reason is, if you're a comprehensive care center, you can provide services in a way under that license in your region that allows for different levels of professionalism. I'll just say it that way. Different training, different requirements there, which are not the same as the behavioral health services organization. I would love for all of our comprehensive care centers to get licensed as a behavioral health services organization and try to provide services all across the state. I think that's a good thing to encourage that kind of, we know we have deficits in professionals across the state. We know we have challenges in providing those services in schools and to other providers and other levels of care. So I think that kind of piece is a good thing. I think if you're going to provide outside of your state-designated region, you should be licensed to provide those services outside that region. So that's the only nuance that I would put to that, and I think that was in keeping with your bill.
Yeah, we've tried to improve it.
Yeah.
Yeah. Thank you, Mr. Secretary.
As a follow-up to that, I was confused by the whole conversation last session. It really got rather very belabored. But people keep referencing that these districts are defined by law. What law is that? I've never seen that.
It's defined by reg. So the statute gives the department the authority to define those. They pretty much follow area development. They do follow area development.
Almost, except for one county.
So they pretty much follow, except for 119 counties, follow the area development districts, which is, again, I think the right thing to do. So that's how they're defined.
So defined by regulation, not by law.
Right.
Because we keep referencing back to John F. Kennedy, and
Right.
I'll say this before I was born.
The regional system was set up by under the Kennedy administration.
Mm-hmm.
So the whole concept of a comprehensive care center was under that statute. You can get me lecturing now. Was under that statute put in place because the point was to provide services in community and to move people out of psychiatric hospitals and provide services in community. What the reality of what happened, and we've all seen it, is folks certainly got moved out of facilities. The psychiatric hospitals are, you had thousands of people in psychiatric hospitals prior to that. So folks got moved out of those facilities, but we never followed up with the funding for community. So what happened, a lot of people get behavioral health services in our prison system, in our correction system. A lot of folks who ended up on the street, and you all have seen it, right, have behavioral health or substance use issues. And because we didn't fully fund the community back in the 60s, fully fund that system for community, we ended up still depending on institutions, but they weren't necessarily licensed to be behavioral health. They were correctional facilities. And that's been something, I'm probably stating it a little too starkly, but I'm pretty close.
But I don't think anywhere does it say these counties
Right.
belong to this region. Like, it's not, I think that's one of the things that maybe I don't remember the final version, but that
So
at
does
one
it
point
make
that was
specific
part of-
reference to the ad districts?
No, I think in the statute's in KRS 210, and it allowed regions and communities to come together to form those regional boards that were to be approved by the Secretary of the Cabinet. That's what's in statute right now. And so those boards were established years ago. That's what the community mental health centers, and as far as I know from the initial establishment, probably the combination of Pathways, which was 2 regions at one time, that's really where they exist.
I think that's the only change from that original setup.
Well, would it give clarity to this whole issue if we named those counties?
Yes.
Yeah, I think it would.
Right. Representative Mosier, you have a question?
Yes, thank you, Mr. Chair. And thank you for your presentation. It was fast, and there's a lot of information. I think on the CMHC, issue that the state contracts with each CMHC and the state defines their region. Is that not the way it's set up?
It's a little complicated. So they were set up, they're community mental health boards. On each mental health board is a definition of who needs to be on it, right? In terms of the county judge and the folks who comprise that region. That then has become, since the initial setup, those are the regions. The only change from there has been the one that we just referenced. So there was an initial setup a long time ago. I'm not sure which secretary it was that did it. But that's what's established those regions. Is that helpful?
Groups came together and kind of said, we want to be a regional board, and that was approved by somebody decades ago, and we have abided by that ever since, because they are boards and they have membership from every county they serve, and then we contract with that board.
Okay. So then, that would mean that the state has jurisdiction about making changes, correct?
Yes, we do.
Okay, right.
Well, it's more collaborative than that. I think if we went in and tried to dictate a change, you all might have us up here and not be happy with us.
Gotcha. All right, Mr. Chair, if I may, that wasn't actually what I was going to ask.
Deja vu all over again.
All right.
Is this a short question?
I have two questions.
Two
Actually, one
short
comment.
questions?
One comment and one
All right,
question.
please proceed.
Okay,
Let's be expeditious.
Well, on the substance use disorder piece, I would agree actually that that BDID kind of stay in the hub and spoke model as the center of that, because I think that there's you have the ability to and you've made a lot of changes in awareness campaigns and so forth to really educate the public on what the underlying issues are as to substance use disorders and all of the co-occurring disorders that happen. And you have the ability to partner with the other departments, the Kentucky Office of Drug Control Policy and so forth, to put policies in place or really understand programs. So I'm not convinced that, we really need to make a change there, maybe other places, but, I do agree that understanding behavioral health is key to addressing substance use disorders. And so that's my comment. And then my question is on slide 9, there are some references to SAMHSA grants or there are grants for assisted outpatient treatment. Is Tim's Law included?
That is Tim's
Oh,
Law.
that is.
Yes,
Okay.
ma'am.
Okay. That was my question. And have these funds been depleted, or are they still being used? Or if not, do they need to be returned? I think it's a multi-year.
It's a multi-year, so
Okay.
there were some funds returned the first year. And I'm not sure where we stand, Stephanie, with the second year. But, we look to expand it. The criteria for this grant was set up before the law was expanded, and it was pretty narrow, and there was no referral that was turned away due to lack of funding. So in order to make a plea to keep our funding, we had to be able to say, so what else are you going to do with it? So we grew the regions.
Yeah.
So we could serve more people and more regions with those same dollars. And
Okay.
But there was a grant where we had about 700,000 left over, and so we had two choices. We could ask for an extension, and then we couldn't spend any of that money until we got the extension, or we could say, hey, can we have 20% of it, and just continue to spend. And what we saw from utilization was that was probably going to be enough. I think there was some real concern on the part of folks from Jefferson County in particular that perhaps their area lost out on funding. I want to be clear, and I think I was clear with the folks who were concerned, that I personally called 7 counties and said, and we are all in agreement, right, that whatever expenses you have, we're going to cover. So I want to be really clear that those expenses related to Tim's Law If there's concern, particularly about Jefferson County, we will find the way to cover it. Because as we look at utilization, it really looks like we'll be able to cover it.
But that'll be outside the grant.
Yeah.
Because we have to, that has to be approved by SAMHSA, so.
Okay.
And we are in conversation with SAMHSA about what's allowable and what's not. We've been back and forth, but we're going to cover it. We don't want folks to feel like they're getting something taken away. That's not the intent.
Okay.
We are in year 3 of the 4-year grant, so there is funding still left. I think the first year we only spent around $374,000, but things hopped up the second year. We did spend around $720,000 for the second year, and we're in the middle of the third year, so there still is grant funding for us to carry forward.
Okay. All right. Thank you. Thank you, Mr. Chair.
I believe Representative Bentley has a follow-up question. Then we have Co-Chair Meade, and I'll cut it off there because we need to move on. We still got a lot of territory to cover.
I just have a comment. The regs list the regions, but the regions are not defined in the statute or regulation.
I thought they were in the regs.
The counties are
The
not.
counties
counties
are in the
aren't,
regs,
but it.
The region.
The counties aren't,
Yeah.
HB 349 would delineate
right,
the regions and
Yes.
no to AD districts.
right, so no place lists these counties belong to these regions, and I think that's one of the things that was trying to be accomplished in
Right.
House Bill
Thank
349,
you.
which I believe we
Yeah.
support.
Co-Chair Meade?
Thank you, Mr. Chairman. I just have a question that just a follow-up to actually something that was covered in the last Child Welfare Oversight Advisory Committee. The Children's Alliance came in and during that meeting and mentioned that psych hospitals are denying care to foster children that are coming from those residential foster care facilities. Is that the case? Are those psych hospitals allowed to refuse that treatment to those who have those severe mental disabilities?
That is a tremendously difficult issue, and it is true. We have psychiatric hospitals that no longer have placement for some kids. The kids that are most difficult to place, those folks who have, those kids who have developmental intellectual disabilities, maybe sexually reactive, have some other behavioral health issues, though, and act out, right, and have some violence issues. Those kids, and they're still kids, are very difficult to place, even out of state. I think when I was up here with social services last time, I identified for you all that's I maybe didn't give it enough drama, but we have kids that occasionally we have no place to place them, and they end up in a DCPS office. That's a terrible outcome until we can find placement. So yes, that is accurate. I've got a group inside the cabinet, because I think this is going to be a 3-pronged approach. There's got to be a short-term issue, and we've been working with Aetna. They're called the Sky. They have the Sky program, which is the foster care. It's a single place where they go. They've been pretty good partners. I have to give them credit, but it's a challenge. Out-of-state facilities, nobody wants. Occasionally, we have to do some of that. Department of Juvenile Justice has some of these same kids. We actually had a meeting with them today to identify some of these challenging issues. We don't necessarily have a great licensed facility placement for these kids because they are so challenging. We think we have maybe DCBS folks think we have 100 to 200 of these kids across the state. I hope that estimate's lower, but I think we've testified before that what we're seeing are kids that are more challenging, more acute, and I think anybody that I think probably they said that to you at Child Welfare Oversight. We have some kids that are really challenging, and we are struggling with placement. Now we're working on it. I've got somebody we're working on, like, what's the short-term solution, right? But then there's going to be a longer-term solution, and we will come back to you all because I think what's appropriate placement? If there's a lot of violence involved, is it a secure placement? Then how do we make sure that we give the proper behavioral health support for these kids, which is a challenge right now, particularly in a secure placement? We've got facilities that are challenged to provide the services, and I'm not sure it's a reimbursement issue. I'm sure it is some. It's always a little bit of that, but I don't know if it's a reimbursement issue because the behaviors are so challenging, and and it's younger and younger kids, and so we're trying to face down that challenge. So we've got to probably come back to you all with what does that look like from how we want to treat these kids in the system, and which system do we want to treat them in, and how do we want to assure that behavioral health service is there. And I can tell you, it's going to be expensive. And it's a challenge. I think every state's seeing it. I don't think we're alone. At least when I talk to other states, we're not alone. But that doesn't mean we don't have an issue that we have to take care of.
And I would just add that all of the state beds are for adults 18 and older. We don't operate any inpatient beds for children.
Yeah. And so, like with adults, we have adult psychiatric facilities where we control the front door, essentially. We control admission. We don't have that with kids, right? We just don't. We don't have any specialty children's. I mean, we don't have a state run where we control the front door, children's psychiatric. We have children's psychiatric, but not where we say, you have to take this kid, right? We don't have that, and it's a challenge within the whole system. And I know you didn't ask that question to open up a whole can of worms, but it really, it's a very, very challenging. If there's something that keeps me up at night, it's that.
I would think maybe the short-term, one of the short-term solutions is bringing us that long-term solution so that we can
So we get
move
working
forward.
on it.
Yeah, and we don't know. I mean, I don't think we've asked other states for their models. Some states, there's a game that states play with Medicaid, and I'm just going to say it. It's a game. You can pay somebody more sometimes by placing a child out of state. So I won't use our state as an example, but like Georgia and North Carolina, right? And sorry if anybody's from Georgia or North Carolina, but Georgia will send kids to North Carolina because they can pay more, and then North Carolina will turn around and send their kids to Georgia because they can pay more in Medicaid, and it's not a good system. And,
No, kids
and
should never be a revenue stream, and that's
Right.
very unfortunate. But
Right.
So we'll look forward to hearing from you with that.
Yeah.
Dr. Stack, you're on deck, buddy. Thank you all. Appreciate your presentation.
Hello, Senator. How you doing?
Doing great. Good to see you. If you would, identify
You
yourself
too.
for the record, and feel free to jump right in.
Turned yourself off.
Thank you. So I'm Stephen Stack. I'm the Commissioner for Public Health and Secretary.
So I have never been over the Department for Public Health. I want you all to know this is one that I've never been over. However, in 1985, when I started working for state government, Certificate of Need and State Health Plan was under public health, so I've actually worked in public health.
Secretary Freeland, you've done this Pontius Pilate things on several occasions. And just, we need to talk about that.
Ready?
Yes, sir.
Very good. So it's a privilege to be here and to talk about the Kentucky Department for Public Health. So there are three words that are often used along with the tagline for public health. It's prevent, promote, protect. And each of those words have meaning. So at the highest level, Kentucky Department for Public Health exists to create healthier people and therefore healthier communities as a result. And we work in support of the Cabinet's overall mission to ensure that every Kentuckian has the opportunity to reach their full human potential. And we do that through these three primary ways. Prevention, if you think about that, is a way to involve guarding against I think this is actually backwards on the slide. Prevention to, like for diabetes and for hypertension and for chronic lung disease and things like that, where we can do targeted interventions to specifically reduce the burden of chronic illness. Promotion would be more to like create a healthier living environment and to try to foster the circumstances and conditions where we would have healthier people. And protection is that there's dangers in the world within which we live, and how can we protect people from those? So think about food safety inspections. There's going to be infections and there's going to be risk of contagion. How do you go do site inspections and make sure that restaurants are safe and that they're using proper hygiene and controls? So we do these kind of activities, and I'm going to go into more detail on the structure of the department. But I thought first we'll talk about the money. Pre-COVID, this agency was about a $360 million in expenditure agency. Obviously, COVID changed things quite a bit. Starting mid to late 2020, additional federal funds were coming into the agency to support COVID-related activities. And then substantial funds really came in and that supported activities in 2022 and 2023 ahead. What will end up happening is by mid-2024, all that federal COVID funding will essentially wash out and be gone. So most of those grants were intended to be available for use through the summer of 23. Every state has asked for extensions for some of the bigger ones, but those extensions now go through about the summer of 24, and at that point it's likely that no further extensions will be granted and the COVID money will be gone. So that's what caused us to grow from a $360 million agency all the way up to about $640 million agency, and it has crested now, and it will then descend back down. Most of those activities were contained with specific things that we did, right? So creating testing capacity, getting PPE, supporting local communities, allocating and helping to facilitate education and distribution of vaccines. So those the money came in for a specific purpose. It was used for that purpose. The purpose is receded. And so we will end up falling back into a more normal footprint for what public health more typically would have been. Now, more normal won't be $360 million. It'll be a bit more because you've all invested in public health transformation, which is in the $17 to $19 million range. So that's helped to increase our resources to local health departments. And there are some federal grants that were specifically created to help with public health workforce development, to try to help build a more robust and a more sustainable public health system. And so there are some of those additional funds. And then, of course, clinical services took a dip in 21 with the peak of the COVID pandemic, like happened in a lot of other areas. And those are now starting to return more to a normal cadence. And so all of that results in a retreat from the peak of the $640 million you see in FY23 down to about $522 million, and then that'll go down into the 400s for millions in the next biennial budget. So we've had quite a journey. I mean, we've really had to expand like an accordion to deal with the pandemic and, of course, deal with a lot of other issues that I'll touch on as I go through the next slides. In a normal year, we are about 3/4 of all of our revenue is federal. And so a lot of resources are passed through from federal grants directly to local health departments to provide services to the people in your communities. We also have some general funds. The general funds is only about a little under 9% of our total on this current fiscal year 22. We also have restricted funds, which we have to work to earn, if you will. You have to get fees for doing inspections, provide Medicaid services, do a number of different things. And then only about 1.5% of our funds are tobacco-related funds.
This public health is the only department where that restricted fund, agency fund, pie piece, there are a lot of fees in there. And so they come in as a restricted fund. So it is not the same percentage that is Medicaid here as it is in every other department. Since I brought it up every department, I thought I'd say it here.
That's the money, and here are the people. So in rough terms, the people of Kentucky, the 4.5 million Kentuckians, are served by about 3,000 public health workers. They come in a variety of different levels and types. At the state level, we have about 550 to 600. It was a little higher, but as we're retreating from some of the COVID activities, it's kind of in a slow downward trend. So we've got about 400 merit staff, about 170 or so either contracted or CDC staff. At the local health departments, and I believe this includes remember we have 120 counties, which you all know well. We have 61 local health departments that serve them. This, I think, captures 58 of those health departments because 3 of them are independent. So Lexington, Louisville, and Northern Kentucky District are independent health departments. So these numbers, I think, reflect the 58 health departments that serve all the other areas of the state. There's 1,500 merit employees, and then they have about 646 contracted employees. And there's a few hundred more people who work in Northern Kentucky District Health Department, Louisville Metro, and Lexington Fayette County Health Department. So you have about 3,100, I think, all in public health workers in the state. I am very proud to serve alongside them. They really do a fantastic job. They work very, very hard. And not all of you, I wish I could communicate more regularly with some, but I know I let Senator Meredith know I was in his own backyard. I've managed to travel to all 61 health departments and visit them in person. I've been to over 75 counties so far, and some of them multiple times, unfortunately due to tragedy, the Western Kentucky tornadoes and the Eastern Kentucky floods. But your folks are wonderful folks who know their communities very well and do really great work, and I'm very proud of the state workers who I believe work hand in hand with them to help support them. So here's our top level organizational chart. I will say I feel good about this. When I started, I was the 5th commissioner in 5 years. It's very, very hard. Senator Meredith, having run healthcare enterprises, it's very, very hard to run a stable organization when you have that kind of revolving leadership. So this senior leadership chart was very pockmarked with vacancies when I started. We now have filled all of these positions. We have every division director filled. We have 7 divisions. We have assistant division directors filled. And we have slightly cleaned up the commissioner's office where we have, you see at the top, there's 3 directors who are cross-cutting in different ways. So we have a new director for public health transformation, and I'll touch on that in the commissioner's office slide. We have a director for health equity that was there before, but is now one of these 3 individuals, and a director of nursing. And those 3 directors support the whole agency, and then the other division directors have bodies of work underneath them. So going through this, so we have 8 slides here, the commissioner's office, and then 7 divisions. We have public health transformation here. So this was a result of legislation in 2020. Senator Alvarado and Representative Mosier played a key role in that, and we are now implementing that. And then funding followed in the most recent biennial budget, so thank you for that. That's essential because your local health departments are eager to rebuild public health and to have it on a sustainable footing, and that funding is essential. So thank you very much, and the commitment to continue funding that is very greatly appreciated and essential for this to be successful. We are working through committees, task forces, work groups in partnership with the local health departments to try to implement the core and foundational model of public health, and then with local health priorities, which are custom tailored on a more specific level based on community health assessments on a health department specific level. So a lot of work underway there. The Office of Health Equity was an existing office. We now have a substantial federal grant, which again, it's kind of tied to the COVID pandemic, will exhaust in 2024. But we strive to help advance health equity and equity in all we do. This means the person in rural Appalachia should have the same chance of success as the person in central Lexington, Kentucky. A person in a community of color should have the same chance of success as a Caucasian person in northern Kentucky urban area. So we are trying to ensure that all 4.5 million Americans, or 4.5 million Kentuckians, have a chance to reach their full potential, and health equity in all its forms helps us with that. Of course, the community health worker program fits in here a little bit. We have a separate area specifically for community health workers, but we are using a substantial amount of the grants here to fund expansion for community health workers. The goal being to have people who are closer to the people they serve, who understand their needs more personally and can help them to navigate our complex healthcare system so they can get the things they need and access services. So we're excited about that. And then public health nurses have long played a really central and important role in public health. And so our director for nursing helps support our public health nurses, but also more generally education on a wide variety of clinical related topics across public health. Division of Maternal and Child Health. These are programs, I'm sure that you'll be familiar with some of the bigger ones. WIC, Women, Infant, and Children, that's a food and nutrition services and a program for children up to age 5. Of course, they had to navigate the infant formula shortage now, which is not resolved, but hopefully is improving. And some of the worst scarcities seem to have abated at this point in time. HANDS program. Now, this is a program that's all throughout statute in a variety of different places. Kentucky, as you've talked about before, has challenges with, healthy childhoods and children having a good upbringing and a chance to have the best, outlook on life. HANDS actually provides home visiting to the home to help young parents, and you can enroll a child either before they're born when you're pregnant or in the first 90 days of their childhood. They go into the home and help model and teach parenting skills. the stories I hear, I'll tell you that the hands workers, as I traveled around, are some of the happiest people across any of the public health workers. The stories they tell will just melt your heart about how they form these bonds with the children and with the parents, how the parents and the children, as they grow up, keep in touch with these workers over a lifetime and will reach out at key moments later on in grade school and in high school and in college. And the program's been around 22 years. But these bonds and the impact is incredible. We're going to really focus hard this year on trying to grow and expand this program and to make it even more so we can reduce the adverse impact of adverse childhood events. I won't go over all of these, but KEYS, that's first steps. That helps where we go into, I think, over 14,000 children we help serve each year who have special needs with substantial disabilities, and that program helps to support those. In the newborn screening, program where we help facilitate follow-up, but also the overall newborn screening. We test for 55 inborn errors in metabolism at the state lab. We find, I think it's about 1 in 400 children are born with one of those inborn errors in metabolism, and trying to help ensure that they don't suffer any preventable harm by intervening quickly at the very beginning before harm occurs. I mean, some of these programs are really impressive. And there are many other ones too, but I won't touch on all of them. Division for Women's Health is the smallest of our divisions. They principally do a women cancer screening program. They get funding to help women who are under 250% of the federal poverty level, who otherwise don't have health insurance or coverage, have access to cervical and breast cancer screening. And if cancer is identified and they meet other criteria, the Kentucky Women Cancer Screening Program has a route to be able to help foster their eligibility for Medicaid coverage if they're eligible, so that they can get services covered and get access to prompt treatment. So this is a wonderful work that they do. And of course, they have the Breast Cancer Education Trust Fund, which is related to the pink license plates that you sometimes see around. And a portion, I think it's $10 out of the $44 fee, get into a separate account to help support breast cancer awareness and research. And they have a committee that specifically disperses funds that come in for that purpose to help support research. So a lot of important work there to support women's health. The Division of Prevention and Quality Improvement, this is all the chronic diseases you would think of. So diabetes, heart disease, colon cancer, and lung cancer. There's new funding and a new program that's being established now because of lung cancer funding that the legislature directed our way this last session. Of course, tobacco prevention and cessation efforts are reside here. Oral health. I had the chance to go visit the Kentucky American Water Plant, treatment plant in Lexington just a month and a half ago, and see the machines and see the plant and all the work that they do to keep our water safe, including fluoridation to try to ensure that we have healthy teeth and strong teeth that have fewer cavities. Healthcare access, this has to do with workforce shortage areas. There's a number of different programs here. We have a role in helping to identify for the federal agency, HRSA, the healthcare shortage areas in our state, which makes them more eligible for certain additional supports. And we oversee the J-1 visa program, which we're allowed to have 30 physicians from other countries who get to come here. The hospitals are the ones who typically sponsor them, and they submit applications and sponsor the physicians. And so I'm in contact periodically with some of the hospital leadership when they have issues and need to deal with that. And then we also, Kentucky Department for Public Health became a public health accredited state health department just this year. It was a 10-year journey getting to that point, and a substantial accomplishment. It's a commitment, just like any other kind of accreditation, to excellence and continuous quality improvement. Our folks who support that effort reside in this division as well. Division of Public Health Protection and Safety. Multiple things here, but think of it in two buckets. The Public Health Preparedness Program is all the emergency disaster response. So for the tornadoes, they help make sure that there were portable showers outside temporary housing for volunteer workers who had come in. They get portable generators to come in to help support people who have lost their electricity. They help facilitate delivery or a donation of medical supplies into an area, a whole bunch of other activities. And they did the same thing in Eastern Kentucky flood area. We have warehouses that we lease that are distributed throughout parts of the state, and our warehouse in Eastern Kentucky became the hub where a lot of the Kentucky Department of Transportation semi-trucks delivering materials we're able to come through and stage things, pick up stuff, and then deliver it to secondary locations. So we play our role as ECSF 8, Emergency Support Function 8, within the Kentucky Emergency Management Incident Command structure. And so we have a pivotal role helping to support people in times of natural and other disaster. The other major parts in this division are all the protection and inspection programs you might be familiar with. So we help oversee the radiation, so like medical radiation, people can do nuclear medicine scans or other types of tests. We help oversee radiation safety in the state. We also do food safety programs at the state level. We inspect food manufacturers. So if you're going to talk about an actual, a peanut butter manufacturer or someone, we would be the ones who go in and do those food safety inspections. Local health departments are the ones who do restaurant inspections and food trucks and things like that. So, and I'll emphasize, it is really a partner between the state and local health departments. I mean, we statute and reg gloriously hold us all accountable and disempower all of us just enough to be able to frustrate each other. It is a system that really requires open communication, collaboration, partnership. I feel really good. I think we've got that at the moment. And I'd encourage you to ask your local health department to see if they feel otherwise. But I think we're in a really good place. We also have a role in milk safety in the state and actually inspect farms for that, where they produce the milk, pool inspections, and a variety of other things. And then I'm going to just touch on this briefly here because I think Commissioner Morris and Secretary Freelander and you all have already discussed it. But we do play a small role here in the substance use disorder with the harm reduction efforts. So this goes to the prevent, promote, protect. You'll notice the word treat is not in the public health paradigm. We generally don't treat disease and illness. We try to help promote it, or prevent it rather, or promote an environment that minimizes its occurrence. But once it's found, other people generally are the ones who deal with treating it. And behavioral health, those are the experts who deal with treating it. Even at the federal level, they have this divided in SAMHSA, the substance for mental health and substance abuse. They integrate those two, and so it really is a treatment medical paradigm. Of course, you're going to have law enforcement and a lot of others who get involved, social services and others, because of the nature of the problem. But I actually do think it is well positioned the way it is in BDID. And we do work in cooperation and partnership. The Kentucky Agency for Substance Abuse Policy, Kentucky ASAP, they have cross-cutting meetings that involve all these different agencies. And there's a lot of communication and partnership. So I think we work very well together. Unfortunately, the problem is tragic and enormous and shows no sign of abating. So I help us all that we can find some path to relief on that. We're getting towards the end here now. Division of Epidemiology and Health Planning. Vital statistics, you get married, you die, you get divorced. They're the ones who track those kind of documents, and so that's an important role. We have infectious disease branch. They deal with healthcare-acquired infections, all reportable diseases, whatever they may be, COVID being the most prominent one recently, monkeypox being another one, that's recent for us, hepatitis, TB. TB is important. I mean, there's multi-drug resistant and extreme multi-drug resistant TB. It is a real global crisis, and we have folks who have to keep tabs on and help ensure treatment for people who have these conditions. It's a big deal. STDs and, of course, HIV/AIDS. Immunizations, we have a whole branch that does that and supports vaccines for children and vaccines for adults. And, of course, in the COVID pandemic, they played a central role helping get that out. And then we have a special partnership with the University of Kentucky for the Kentucky Injury Prevention Research Center, KIPRC. And KIPRC does a whole host of work in partnership with us and also some additional work they do on their own that they get separate funding for. I just visited with the director of KIPRC at their location in Lexington in the last couple of weeks, and we have a really close partnership with them and are grateful for that and our other university partnerships in the state. Division for Laboratory Services, and I only have one more after this. Our lab is a gem. There's nothing like it in the state of Kentucky. So it is the only place that does all that newborn screening for about 55,000 live births. If that lab were to go offline, we have to ship it to another state. There is no other in-state alternative for that. And it's much more expensive if we do that, by the way. We also are the only BSL Level 3 lab. It's a biosafety Level 3 lab in the entire Commonwealth. The only higher level is BSL 4, and that's what you have at Emory and in New York, and those are the Ebola places. Those are the scary biotox places. But our folks will deal with anthrax and ricin and other extreme pathogens, our lab is the one that would test for those substances should there be a need to. There is no alternative in the state. We'd have to ship it, I think, over to Tennessee as our backup. There's a variety of other things that they do. I'm only going to say this verbally, but I'm going to say at every hearing I have the privilege to be in front of y'all. We've got to get in the next capital budget a new lab. The lab is 30 years old. The machines do things that are like Star Trek level now compared to when the building was built. They generate heat, humidity, and require the kind of infrastructure controls that just didn't exist when our lab was built 30 years ago. We are in, I think, a situation with a risk of operational failure. And remember, any lab that's built, it's going to be a 5-year project. It's going to be designed to build, and we're talking summer of 24 before it could start. So you're talking 29, 30 before it's move in. You're going to be almost 40 years old. So it won't be me. It'll be some other commissioner and some other governor and probably a whole bunch of other legislature who gets to go cut the ribbon. But we all need to give that resource to the people of Kentucky in the future. It's that important, and I'll keep saying it. I just urge you to look at that in the next budget cycle, please. And then we have a division that just does administration and financial management. This one is invaluable. They're the ones who help support the local health departments, make sure all this funding that goes through the state to the locals gets done properly, that we work with them to support the HR functions we have to, do a whole lot of other things too, but they're the quiet behind the scenes folks who just help make sure the rest of us can get all this other stuff done. And my final slide, we work with every agency in the Cabinet for Health and Family Services. I just want to emphasize that. We worked with the OIG closely when we went through all the COVID stuff with all the disruptions in healthcare. We worked with Dale to help make sure that people who were vulnerable and homebound could get vaccines for COVID, or in the flood-impacted areas or the tornado-impacted areas. Dale was invaluable to help make sure they could support our function in Kentucky Emergency Management. We work with the substance use disorder problems and harm reduction in a great way. And I could go on it. We have partnerships with every single one of our sister agencies, and we work regularly with them. I couldn't be more proud again to be part of that team and to serve alongside my colleagues. I really do think having these agencies proximate and under the leadership of a single cabinet secretary has made it possible for us to do things. State government is frustrating. I hope I'm not telling you something you don't know. Any big company is difficult. Any big company would be difficult, but the bureaucracy that goes with navigating it is very difficult at times to navigate. I don't know how in the world you could really survive if we separated out some of these things and had to go across cabinet. That level of communication is just intrinsically much more difficult, and I think that this serves us very well having us under one roof. Senator, that's the end of my set remarks, and I am happy
We
to
appreciate that, and we will open up for questions. And the first one I'd have with you, if you could elaborate what your relationship is with the Department of Medicaid. You made reference to it, but
Yeah.
can you elaborate on it?
Yeah, so again, so the HANDS program, for example. HANDS program, our largest, so it's funded by 3 funders. There's some tobacco funds, there's Medicaid funds, and there's HRSA McVie funds from a federal agency. Medicaid's the biggest funder of the 3. And we use tobacco funds for a match to make sure that we can draw down the money from Medicaid. So we administer that program. So the health departments bill through us in order to provide those services for home visitation for families. Medicaid then pays, it gets paid out through us. And so that whole program is incredibly valuable. And without the partnership for Medicaid, we wouldn't be able to do that and to do that way.
Another piece, and I think I've testified about this before, but something that I've been wanting to do forever was have basically a medical staff at the Cabinet for Health and Family Services. The CMO of the medical staff is right here. Dr. Stack, as the Commissioner for Public Health, I think is rightfully the head of the medical staff at the cabinet. So that includes the Medicaid medical director and the DCBS physician and Dr. Brenzel and the host of physicians that actually work really closely with the cabinet. And an example, the first piece I gave them was to help us define the quality measures for hospitals on the HRIP, on the reinsurance. The reimbursement program for hospitals, to define what it is that we want to see from quality measures from the hospitals for that additional funding up to the average commercial rate, which has helped our hospitals. I think they've testified to you about that. But the medical staff came up with a list of quality measures. Hospital Association came with a list of quality measures, and we worked together to come up with that list for the HRIP program. I think I'm talking with Nancy Galvani. I think we're going to see some good quality, at least she promises, good progress on quality. But that's another way that we're trying to integrate our physician resources to impact basically all the programs. But since you asked about Medicaid, that was actually the first task.
And rightfully so. You know, I've said on numerous occasions myself that one of the good things that came out of COVID was it elevated the importance of public health, particularly in our state. And I think for the most part, done an exceptional job. But I think it should grow even beyond that. You know, your mission statement says our mission is to improve the health and safety of the people in Kentucky. Well, I think we've advocated that responsibility for a third of our population to MCOs. And I don't understand why there's not a more direct relationship between the Department of Public Health and the MCOs rather than have to go through the Department of Medicaid for that. That makes very little sense to me. I mean, do you see managed care as a quality of care function or is it a fiscal function?
Well, so it's interesting. So I try to have to separate some. Remember, I'm a past president of the American Medical Association. I engaged in public policy at the federal level for quite a while. So, but that's not my role right now today. My role is as the Commissioner for Public Health in Kentucky. So in a public health role, we do have incredible partnerships. I'm going to come back straight to what you said, Senator, but I'm going to think about community health workers as an example. Representative Mosier passed legislation, and so there's efforts afoot to expand further community health workers. But there are different parts of it. There's the certification part. That's solidly in our area. We're currently involved in helping to certify folks and support the profession. The funding part is in the Medicaid part, additional funding. We have some grant funding, but the sustainability would be more Medicaid. That's the Commissioner for Medicaid Services. But we've worked together, the two of us, within the confines of our cabinet, across the cabinet, on biweekly meetings to try to come up with how we're going to handle that and work together so that it is sensitive to the needs of the community health workers, but also sensitive to the constraints that Commissioner for Medicaid Services has to deal with. Now, when it comes to talking about population health and wellness, I'm an unabashed promoter for public health and the things that we can do and the role we can play. But what public health generally is not is a major finance resource allocator or someone, you know, like if the local health departments and the Kentucky Department for Public Health could never really approximate what Division for Medicaid Services does or what an MCO does. Now, I'm never going to sit, I'm a physician, I'm an emergency doc for 25 years. You're never going to have me sit down here and advocate on behalf, and I don't think so, on behalf of for-profit health insurance companies, because I think there are great difficulties and conflicts that ensue with that. So I'm not going to argue against your point, Senator. I tend to probably agree with the part that I'm not sure what value MCOs provide. I'm also, though, not sure what role public health, as it is generally conceived across the country for its role, there would have to be more thoughtful discussion about what role it could or couldn't play.
And I think there should be. You know, we've had the managed care model for over a decade now, and I'm not here to bash MCOs, but I am here to bash the model. They have not improved the health population. When it started, we were 47th in the nation. Now we're 44, and I think that's more to do with the fact that people have coverage they haven't had before, but they have not improved the health population. So when we say the mission of public health is to improve the health of the population and safety, we failed in that if we're not providing more direct oversight for the MCOs. And quite truthfully, I think that the managed care function should be a function of public health. MCOs have their roles, not as a managed care, but as an insurance company to process a claim. So you can distinguish between the two. Medicaid should be the fiscal arm of it. But as far as the quality of care side of it, I think that's a public health function, should be. Because how can we say we're improving the health of the population when we haven't? And we've advocated that responsibility, a third of our population, to an insurance company who has an obvious conflict of interest there. So I think this could be addressed. You know, we hear a lot of recommendations during our sessions about how to improve the health, such as I remember the Hep C discussion we had. Well, personally, I think if Medicaid or the MCOs are responsible for improving the health of the population, that should have been something they undertook years ago, but they had no reason to because the contract doesn't call for it. That certainly is a public health function. And if you folks were directing the managed care portion of Medicaid, I think those things would be done. Another thing we've struggled with for years is we're supposed to have a trauma network in Kentucky. Been established by law years ago, but has never become operational. That's costing lives in this state. It's costing money in this state. Why isn't that a public health function? And why don't we incorporate that in there and fund that as it should be? So again, I want to give you a broader role.
Oh, no,
but
I get
we can't
that.
pick and choose what we do. If somebody's got responsible for the health of the population, and that's part of the reason we're feeling so miserably, is nobody is accountable. Now, you folks have some measure of it because of the specifics that you do, but you're kind of treating the symptoms, not curing the disease. We've got to change that model. And I think there's a role in public health to do that if you folks are willing to embrace it. But that's a concern of mine. I think we've advocated that responsibility to a third party that we shouldn't, but that's me. Senator Berg, you have a question, comment?
Thank you, Mr. Chairman. I have both a comment and a question. First of all, thank you for a very interesting presentation. I am a huge proponent of public health, and I really appreciate everything that you shared with us today. I do have a serious question that I noticed we did not discuss, and is perhaps a personal mission of mine. Based on where I have worked for so many years, I am unfortunately sit in the back of the emergency room at University of Louisville Hospital, and started actually the Department of Emergency Radiology there over 30 years ago, and now I'm back. And we have a real serious public health crisis in this nation and in this state with gun violence. And I did not see it addressed on any of our slides. I'm going to share a little bit of data. The state is it's costing us approximately $500,000 per gunshot wound victim in this state is what we're paying right now. And almost $900,000 per homicide. So when we have 6 gunshot wounds in one weekend, we are literally putting out $3 million of public assets and getting nothing in return. And I think this is data, I'm speaking to the choir, I am sure. But I just want to make sure that people understand the extent of the cost that this public health crisis is costing us. Averages are that Kentucky alone spends $5 billion from top to bottom on the cost of gunshot wounds and deaths annually, 181 million of which is actually paid by Kentucky taxpayers. $181 million annually, guys. And I think this is a public health crisis that we, for some reason, refuse to discuss, refuse to address. And I'm just going to ask you, sir, is there a way that you think we can move forward on this issue or not?
I had an answer to that. I would really be a special person. So one of the last things I did as I was leaving office as president of the American Medical Association was on behalf of the AMA to declare gun violence a public health emergency. Gun violence, okay, I'm not talking about the guns themselves and stuff. There's all sorts of complexity there, but gun violence is a public health emergency. Now, beyond that, and I will say that unapologetically, I really believe it to be the case, and I desperately think as a society we have to find a way to have discussions about how can we allow gun owners to have the use of their guns and to honor the Second Amendment for the way it was intended to be written, but to allow the rest of society not to have this really epidemic of gun-related violence. Beyond that, it's as muddy as you all see. It is a very divisive issue. It is very complicated and difficult. Of course, I would not shirk from my role as a public health official in Kentucky dialoguing on it, but I also would not claim to have any answers, and I would also think we have to find a way to create safe spaces where people will sit down and have the hard discussions that need to happen if we're going to address it in a way that has a chance of getting majority votes out of a legislature and a governor's signature and nationwide. The same thing for Congress and the nation, and you've seen the difficulty. You live it. You are elected leaders in the state. I just hope that we can all somehow find a way to find a better path through this, but it has been obviously challenging.
A follow-up, sir.
Briefly, yes.
First of all, thank you for your answer. A follow-up question: are we aware of any federal dollars that we can bring into this state under the new legislation that would help us enact some common sense gun legislation in this state that might decrease the amount of gun violence we're seeing and have a positive impact on the amount of money we're spending on this issue? Under Biden's new plans for, incentivizing states to come up with better common sense gun legislation, do you have any awareness of that?
I do not through the public health avenues that I'm aware of.
All right. Thank you.
Representative Moser.
Thank you, Mr. Chair. Thank you for being here. I appreciate all the work that you do, genuinely, and we've known each other a long time. So I know it hasn't been an easy job these past couple of years. So thank you. I have a question, maybe a comment first, and a question about, you talked a little bit about the role that DPH plays in addressing substance use disorders. In keeping with the core and foundational services that the local health departments are now tasked with staying on task with. We've kind of gotten away from the unwieldy local health departments to really focus on those issues. I think the one area that we can really focus on in dealing with substance use disorders is the HANDS program, and I'm really happy to hear that you're looking to expand it. I don't know exactly what that involves in getting more federal funds, because a great deal of the funding comes from the federal dollars and tobacco settlement. But I do think that it has the potential to really have long-term lasting effects on the families. And when we're talking about things like gun violence and violence in general and substance use disorders, I think when we address the core problems with the families and the children and address the trauma and all of the things that come with challenges that families are struggling with, I think that we really have an opportunity to mitigate those negative effects. And I believe that about early childhood learning. I believe that this is a program that can really help address some of that. And I think that that's maybe more of a solution than the whole gun control issue is a big difficult conversation. But if you really want to address what's going on in our society, we've got to interrupt the cycle of all of this dysfunction that we're seeing, and we have to do it early and help kids and families build healthy coping skills and resiliency. And we can't be all things to all people, but if we know that we have a program that works, I say we expand it. Is there anything else that you see that the local health departments can do to help with the substance use problem?
We have the most number of syringe service programs in the United States in Kentucky. We also are one of the states most adversely impacted by substance use disorder. We have really wonderful collaborative efforts like I've described with BDID in our own cabinet for behavioral health, but also with Justice, with Ann Ingram, the Kentucky Office of Drug Control Policy, and others. What I observe across the country is, despite a lot of people's really, really concerted and sincere efforts, none of us have figured out how to turn the tide on this, and it's only gotten worse. And of course, there's multifactorial. You could say COVID contributed to it, because COVID contributed a sense of isolation, and that contributed to it. But But the fentanyl products, the fentanyl that's coming in from overseas and the synthetic fentanyls that are just so potent at killing people, it's multifactorial. So Representative, I really wish I had an answer. And you know, I'll be straight if I think I have a thought on how we can navigate something. But a lot of people have really spent a lot of effort trying to figure out how we could turn that tide, and we have not figured that out yet. We just have not, and we've got to hopefully do better. And for the HANDS program, the program's been around 22 years. And remember, when I say these long horizons, I do that. Hopefully, that helps to put in context. This is not about one administration or one legislative session or anything. This is like a long time, 22 years. We just gave the first rate increases in 22 years in that program to the providers doing it. I mean, we're doing other things to draw down additional federal funding to provide additional support to the local health departments. And I attended the HANDS conference with over 300 HANDS workers from around the state just a couple of weeks ago, 2 or 3 weeks ago. So I do think if we can do some blocking and tackling and invest in the structure and the infrastructure, the things you've done, giving an 8% increment and hopefully another one next year for state workers, and the things we need to do with addressing personnel issues across state government, you can't, any of you working in healthcare, we're paying nurses, or at least we're trying to pretend to pay nurses. None of them will work for us anymore. We're trying to pretend to pay them wages from 20 years ago at a time when the whole current shortage has escalated all their prices. If we don't have a way to address those things more nimbly, we can't get people to serve in these roles. And so the efforts that have started more recently, and I think I'm optimistic, I hope, will continue, for us to find a way to recognize and support the workforce that works at the state and at the local level will be invaluable to our success. But I do think we can together accomplish some good stuff.
Thank you.
Thank you.
Could I ask you, and certainly we could spend a couple of days just talking about substance abuse, but I'm kind of curious as to what our philosophy is right now. Is it kind of accept and kind of surrender a little bit? Because I know that some departments have supported programs to, shall I say, support the safe use of illegal drugs. Is that really the position we want to take? I don't think it's widespread. I know that Louisville specifically had a program this past summer when one of the larger events they actively promoted that, here's Narcan and be sure you practice safe drug use. Is that the philosophy we're going to follow?
Well, no, this is tough. And I traveled to a local city council and talked about this. It's hard. Here's the situation we have. They're called harm reduction initiatives for a reason, and I may even distort this from what the harm reduction community would prefer I say, but the problem of substance use, and particularly injected substance use, exists. It is there. It is growing for reasons that have been difficult to control. The fact that they're going to use the substances and inject the substances is happening and going to happen. The problem is when they do that. So will we try to figure out that problem? The harm reduction is trying to make sure they don't get bloodborne infections at the same time, that they don't get HIV and hepatitis, that they don't get bacterial endocarditis, that they don't end up having a valve replacement, that they're not in the hospital for 6 weeks, getting intravenous antibiotics. So the harm reduction is not to potentiate, promote, indulge, support, encourage the use of drugs. It's absolutely not that. It's the recognition that it is happening. And absent other interventions, we will pay more. So it's about the person we're trying to help, but it's actually about society at large too, because all these folks consume massive amounts of economic resources. They drive away surgeons from your smaller communities because people have all these abscesses and they come in and then the surgeons say, I can't keep doing this. I can't constantly do that. I'm going to leave your communities. You may know some surgeon who's shared this. Infectious disease doctors, it's difficult because the patient with substance use disorder has a medical problem where their brain chemistry is horribly altered. it's not a volitional choice. Once it may have been a choice to try it, but very quickly it becomes a real chemical imbalance in the brain that is not just a thing based in logic. It's an incapacity to overcome without outside help. And so the situation is not, are we promoting it? No, I absolutely have no interest in promoting substance use disorder, but it's, are we going to allow all those other harms to happen too, which not only hurt the individual afflicted by substance use disorder, but hurt all of us? Because then you don't have surgeons in your communities, you don't have infectious disease doctors because they leave to get out of there to go somewhere where there's more support. You don't have, your health insurance premiums go up. Because remember, in the United States, EMTALA guarantees everybody's going to get the most expensive part of the care. They're just not going to get the rest of the care that keeps them healthy. So when they fall to their low, they'll go to a hospital, go to an emergency department, get admitted to a hospital, get transferred to a bigger hospital to get all that care that somehow we all have to pay for. It's just when they get discharged, if they have no access to care, then the recidivism kicks in and they fall right back into the pit they came from. So no, Senator, I am sympathetic to the concern that it appears like, well, why are you promoting this? I have no desire to promote this. None of us do. And certainly Commissioner Morris and her colleagues at BEAT, no one's given up on trying to find a way to treat it. But it has unfortunately been diminished, really difficult to find a way to treat it. But harm reduction is to spare us all those other calamities occurring in addition to the primary calamity, which is the using of the substance.
Final question, because we need to move on, and I'm going to take chair prerogative here and ask this one as well. In your Division of Prevention and Quality Improvement, you talk about healthcare access. You know, we've heard 5 of our 6 MCOs presentations, and one of them is network adequacy. And each of them have said that they're meeting that standard like 90+%. Do you believe that?
No, I don't. But that's me just. When I was in a different role, Senator Alvarado kindly tried to facilitate communication between the provider community and the private health insurer community, and no, I will remain a skeptic. There are incredible barriers to people getting the care that they need, and roadblocks administratively. Prior authorization is an enormous one that is burning out physicians and causing all sorts of other harms to the clinical workforce. So, no, I think there are complex discussions there, and I think there's a lot of work that needs to be done to have meaningful adequacy for people to have access to care.
Well, I think it goes back again to is what's the role of public health and how broad of base responsibility we're going to allow to public health, and I think it should be broad. But, you know, over the last couple of years, we've taken measures like the mask mandates and vaccine mandates and shutting down business, shutting down daycare, which has, been terrible for rural communities, is how on one hand we're willing to make those broad decisions about our state, but we're not going to accept the full responsibility for the health of the population. How do you meld those two things? And how can you make a decision? And maybe it goes back to the methodology of how do you make those decisions that we should close daycares or that everybody wears a mask? What's that process? Is there a process? For that health policy, you got something like on an emergency basis, here's where we are, here's what we need to do. But on a more long term is, that problem's there, but we're not going to do anything about it. So.
No, the reason I paused was I was listening to you attentively and thinking that there's some things that there's opportunity for dialogue, and then your inflection made it a question, and that's what caught me off guard. So it is really tough, and it's a reasonable societal debate to discuss when and where do you intervene and how do you do it. I think COVID's a once-in-a-century event. Let us all hope none of us have to live through another once-in-a-century event like that. I mean, look, we're dealing with other things now, like Ebola in Uganda, which thank goodness is not here in the United States as far as we know now, but we're trying to surveil for that. We deal with TB all the time. We got monkeypox, and none of those interventions have anywhere, remotely been like COVID. So COVID, I think, was really unique. But as far as how those decisions are made and all, it's supposed to be a partnership, across society for public and private. There's a role for the legislature, a role for the executive branch of the government, and at times when there's disputes, there's a role for the judiciary. I mean, it's complicated, right?
It is complicated, but I think we could argue that, we'd like to see a partnership, but we really weren't involved in those decisions and think we should have been, but I don't want to get in that today. I appreciate your testimony, and again, I want to see a broader role for public health and for what you do for Kentucky, but I appreciate you being here today. We need to move on to our last department, and that's Family Resource Center and Volunteer Services. If you folks will come forward. Again, Dr. Stack, thank you for being here this afternoon.
Introduce yourself.
If you would, please identify yourself for the record and feel free to proceed with your presentation.
Hello, I'm Joe Braingardner, the Executive Director of Serve Kentucky.
I'm Melissa Goins, the Director for the Family Resource and Youth Services Center Division at the Cabinet for Health and Family Services.
And yes, I was over these groups at one point in time. And as a matter of fact, before the Family Resource Center division became a division, it was a branch, and I was the branch manager there. These are the good news programs. I love these programs. I never get any bad news out of them. They always, what they do in our communities, what they do in our schools, makes such a tremendous difference in response to emergencies, both that they have done. The impact on children, these are programs that have such, for their size, their impact is so broad, and I think it really brings and highlights what I think is best about Kentucky.
Thank you. So our department is comprised of two divisions. The Family Resource and Youth Services Center Division was established as a component of the 1990 CARA Act, or CARA, and was placed in CHFS.
And Serve Kentucky, established by the State Commission under 42 USC to administer grants from the Federal AmeriCorps Agency.
This is a snapshot of our budget. We're majority general fund, and Frisk has about 70% of our budget. So when we look at the purpose of the Family Resource and Youth Services Centers, our goal is to assist at-risk students by mitigating, eliminating, reducing non-cognitive, non-academic barriers to learning. And schools in our state with at least 20% free reduced lunch student population qualify for a center. And right at this minute, all of our schools that have 20% free reduced lunch and want to have a family resource center have one. Our funding is divided among 887 centers serving almost 1,200 schools, which is the majority of our schools in Kentucky. We're in 167 districts, and schools receive between almost $38,000 and then $94,500 to operate a center, and that is based on a formula and a per student amount. So these are our components set forth by KRS 156496. Our family resource centers are in our elementary schools, so you can see that that a lot of those components are around earlier learning and early childhood. And then our youth services centers migrate over to our middle and high schools and involve things like substance use education, job development, career development, family crisis and mental health counseling as well. So we really believe that activities should be driven by local need. That's the way this program was set up from the beginning. And so we do have a process for that. Each of our FRISC completes a school and community specific needs assessment. They're required to do it every 2 years. Some of them do it every year, where they look at what needs they have in their community. They do this in a variety of ways. I'm happy to go into it if you have questions. And they also analyze their resources, because we certainly don't want any of our family resource youth services centers to duplicate efforts that are already happening in their community. They submit a program plan to our division that's tailored to meet their local need, and then we approve those plans, give them feedback on those plans. And one of the biggest things that we consider as we're looking at those plans is how they're going to measure success. How are they going to evaluate what they're planning to do? How is it tied back to the needs that they've identified, and how are we going to measure what they're doing? Our data is collected in Infinite Campus and in FRISC counts. Infinite Campus, as you guys are probably aware, is the school-based system, and it works really well for most of what our family resource youth services centers do. Allows us to coordinate services with other people in the building around students and families. But there are some things that our FRISC are responsible for that will never go into Infinite Campus because they're not about kids who are enrolled. For example, our families in training component is our early childhood component, and when you're working with kids 0 to 3 or even prenatal, those kids aren't enrolled in school, and so there was nowhere to plug that data. And so we worked with our coordinators. We didn't want to do something overly burdensome, but they really wanted us to be able to count what they're doing. And so we developed our Frisk count system. And so I can say that for the last 4 years, we probably have 4 solid years of better data, which is going to lead me to talk about some of our state level outcomes. So this is a snapshot. I have 2 things I just want to pull out because I know we're short on time. Something we're really proud of is our FRIS reported over 17 million, and this is fiscal year 22. Our FRIS reported $17 million in cash and in-kind contributions from their communities. So this is cash donations, this is time, volunteer time. People who volunteer for our centers. And then our backpack program, a lot of you may be familiar with that. Our FRISs are kind of known for that. We provided almost 300,000 meals for students. And I just want to point out that the majority of our FRIS that organize something like our backpack program don't use general funds for that. They partner with their faith-based community and other community organizations to make that happen. And then lastly, our grandparent support. We had over 7,000 grandparents and relatives that participated in FRISC-led parent-relative support activities. And then there's some other data points on the bottom there as well. I wanted to share a couple things about outcome data. So we, our FRISCs, you know, I referenced, we look at how they're going to measure their activities when they submit their program plans. And so after they are complete a cycle with us, they send in really every year some outcome and impact level data. And so I provided an example for you here. I actually have 2 examples on here. I'm not going to read this to you, but you can see that a majority of the students that participated in this summer program increased their graduation score, had gains in their math and reading as well. And then this one I love to share because this is so quintessential Frisk. It's our Build-A-Bed work. And so we partner with folks in Serve Kentucky, folks in the community, to build beds and get beds donated for kids. And so in this instance, we had 10 students that said that they needed beds. And it's, you know, not unusual. I'm sure over the, 30 years of this program, we've had lots of Frisks, get lots of beds for lots of kids. But what's different about this is that over the last, 5 years or so, we've really been pushing this local level outcome data. This Family Resource Center coordinator really looked at grades and attendance and how getting a bed for these students really impacted those educational outcomes. They surveyed the students and found that they reported better sleep. We educated the students on the importance of sleep, which we all know is going to impact performance, right? And so this we're really, really proud of. I think that you have a 1-page summary with a QR code that has our full report for the past year. We have reports from 2016 on our website. I'm happy to send you things that are within your district, or if you have a certain area that you're interested in, we can send you some local level outcome data on that. And then as far as our state level outcome data efforts, I've already talked about data collection enhancement. So I'm going to skip to bullet 3, our social return on investment study. Now that we have better data for several years in a row, we have started the process in procuring a social return on investment study, which I'm so excited. I hope to come back next year and hand it to all of you. The second bullet, our statewide standards of quality, quality of practice standards. We adopted those about 4 years ago. We talk a lot about ACEs, and so it made all the sense in the world to me for our Frisks to have standards of quality and practice that are based on protective factors. So as they're looking at the activities that they're doing in a 2-year cycle, they're looking at how they can develop concrete supports in times of need for our families. They're looking at the protective factors and the principles of engaging families and kind of running it through that filter, if you will, as they're looking at their activities, which is helping us to have more quality and consistency across the state. It's harder to do when you have a lot of local flexibility, but we believe that we're getting a better balance. And then lastly, collecting success stories. I believe you have one in your packet. I'm not going to go into it, but we believe that will always be a part of what we do. It's really difficult to distill everything that we do down into data points. There's always going to be those times when we put a lot of effort into a particular student and I believe that we change the trajectory of his whole future and future generations for that family. And I think that's all for me.
Wonderful. Great. So Serve Kentucky is the organization that oversees the AmeriCorps programs across the state. We do a lot of work also with volunteer work and in disaster recovery, but AmeriCorps, to give you an idea, is sort of like a domestic Peace Corps. And what's really powerful behind what we do when we start a corps, we work with local champions that find a need, they assess a community, they find something that they want to do to address that need. We help them build a corps, we help them bring in federal dollars, and they recruit the members in that community that will serve for a year addressing that need. So again, the power behind what we do is folks that are locally doing this work. We build really, really strong public and private partnerships, which is, again, at the heart of all the work that we do. So there's got to be local buy-in. This isn't a large federal program that's sending people to Appalachia to work on housing. It's basically a partnership that we do that's going to show sustainability, and the percentage that folks need to put on the table increases the longer that they're in an AmeriCorps program. After you've been a program for 10 years, 50% of your entire budget has got to be public investment. So I think that that's a real strong aspect of who we are. It's also perceived as like a multi-tool. In a lot of areas where there's sort of like a gap in social services, people have found that AmeriCorps is an excellent place where we can pop in, parachute in, and really help build some capacity there. Uniquely, our budget, if you look at our budget, we're tiny, man. I mean, we are the Mighty Mouse of the cabinet, I think. We're the cowbell in the band. But that Mighty Mouse cowbell, we leverage that to bring $24 million into the Commonwealth of Kentucky. And we do that with that local match, and we do it with the Education Award, because every AmeriCorps member that serves in Kentucky is going to get this Education Award that they can then go on and further their education or pay off their back student loans. Couple examples down there of the kind of work that we do. We do quite a bit of work in the senior care community, where basically we got to have a companions program. In AmeriCorps, there are 40 across the state, about 4,400 senior corps members that are actively working in centers, mostly serving as companions or as foster grandparents. We heard earlier and we did about the Too Good for Drugs program. That's run by Operation Unite. We've got Unite Service Corps that's been actively working with that program for very, very long. And we've been mentoring and tutoring in schools in about 80 counties for the last 10 years. A couple of pieces here just about some impact, just some numbers so you can see the Teach for America program. It is a national program where folks that want to be teachers go into an underserved community and they teach for a year, typically in the STEM field. So we've had a really, really strong presence down in Appalachia with our Teach for America program. Again, we've had 83 that we brought in. We've got 58 that are still teaching. A couple other examples there that I'm really proud of. The one near the end, I'll just kind of skip through quickly, is a new partnership that we have with Public Health. And we have the second largest public health corps program in the country, where we're going to have 275 people in 2 different corps that are working in local public health centers and in long-term care where we can't get people to work any longer. And they're coming in and serving for a year, and the hope is that they're going to be onboarded into that field as well. Next. So our state service plan, I put this on the desk for all y'all if you want to check this out a little bit later. It was a pretty robust plan that we put together with our governor-appointed commissioners and our staff and all of our champions, where we did a pretty in-depth year-and-a-half study and survey of volunteering in Kentucky and service. You know, the kind of things people want to see and do, how we can better serve and why. That's in that state service plan. And there's some pretty eye-popping information you'll see. So we're really, really proud of what we came out in this plan. These are the 4 key elements. Mainly, we are going to lead the nation in impact. We have grown about 400% in the last 9 years. And that's only because we've built the staff and the commissioners that have shown the kind of input that want to do that. We really need to expand more the volunteer base in Kentucky to meet those needs every day. You guys probably heard this before. 1 in 10 people employed in Kentucky work at a nonprofit. 1 in 10. No nonprofit in Kentucky exists without volunteers. I come from that world. I worked in nonprofits for 22 years, and we don't exist without those volunteers. So we're going to keep raising that base up. It's also economically strong, and it's good for workforce, because in Kentucky, if you volunteer 20 hours a week for a year, and you're unemployed, you are 57% more likely to find full-time employment. So we know that it's just smart for people to volunteer. We got to tell our story across the Commonwealth. This A that I proudly wear, people don't know who we are, and we need to do a better job of that. The disasters we've seen in both sides of the state, we were on the ground 24 hours after those disasters, some during the disasters actually still happening. And we're still there, and we're going to be there years after everyone else is gone. That's what we do during disaster time. But we need to do a better job of sharing our story and helping people see who we are. It's my dream someday I don't have to look at y'all and say we're a domestic Peace Corps, where I want to say the Peace Corps, that's kind of like International AmeriCorps. You know, that's kind of where we're going for someday. And then lastly, we want to continue to do the important work in the disaster zones. We get disasters, as we know, every single year. It's not just big floods or a tornado comes from time to time. It is the winter ice storms we get. It's the constant flooding. And what we can provide, AmeriCorps members, our alumni, if you've ever heard of Team Rubicon, that was birthed from AmeriCorps. These are combat veterans that are there on the ground and doing the hardest work that's needed immediately. Our members right now, 2 days ago, I was down in southeastern Kentucky mucking and gutting with 2 different teams of AmeriCorps members. We'll be down there doing that until we don't have to do it any longer. In western Kentucky, we're part of the Habitat projects, rebuilding those houses that were all blown away and those businesses that we need to bring back. So big key part of who we are. And lastly, the map, we have 2 different maps. This one I love showing because it shows where our programs are. If you see the little white blur, that no programs, we have no program counties in Kentucky. 9 years ago, that map would have been completely different. We would have had about maybe 20% of the programs. We were serving in maybe 40 counties. So we are literally taking people power and serving in every single county in Kentucky through AmeriCorps. So a little bit about the map there. The last couple of things that I want to mention that I love about who we are and what we do. I think that's a lot. Is that the last slide? Okay. About who we are and what we do. About 9 years ago, General Henry McChrystal put together a committee through the Aspen Institute. It's called the Franklin Project. And 19 different 4-star generals joined General McChrystal, and they came up with a plan seeing that less than 1% of Americans serve in the military. Less than 1%. And they're not having ways in other ways of impacting and serving their country. This is a way that we can do that. Top military brass have seen that this can't be the only way to serve your country any longer. Going in the military, of course, it's wonderful. It's a great thing to do, but we've got to give you other aspects of doing it. National service is a way of doing that. So we're putting a lot more focus into doing that. And it's also a way that we continue to work with veterans, right? We have thousands of veterans that serve every year in Kentucky after they retire. They find it's a way they can keep serving their country. Really proud of that work. So lastly, I just want to end it this way. AmeriCorps really, it is for Kentuckians who sometimes need a second chance or a third chance in life. It is for seniors who want to stay connected to their families and their communities, and they know volunteering is going to keep them viral and healthy and young. It's for young people that need resources to go back to school, to get a degree, or to pay off their student loans, or to get out of mom and dad's house. We're going to help them do that. It's for people that want to build skill sets so they're better poised to go into the workforce. And lastly and personally, it's for people like me. I did this in 1989. I was in Vista, because I needed direction in my life. I needed something to do. But most importantly, it was a promise I gave to my mom and dad that I was going to do something for my country. And that led me to Kentucky. And 33 years later, I'm still here serving the people because of that. So that's who we are. And thank you for this time. Glad to be here. Questions?
First question would be, do you have any passion for this program at all?
Sir, I can afterwards, when I used to work at the YMCA and I brought all the kids here, afterwards we'd have a pizza party and a dance. And I'll do that for y'all afterwards soon.
Well, it was a rhetorical question.
Representative Mead, I'm going to give up my auctioneer title to thee.
He did a good job, that's for sure.
Thank you.
First of all, I'll say that thank you all for being here. I think I speak on behalf of the entire General Assembly, but especially those from rural communities. We love you guys. We appreciate what you do. Appreciate your service to our communities. And Joe, I'll also say that you mentioned that your organization was the cowbell. I guess to take a line from Saturday Night Live, I guess we need a little more cowbell. But I do have one question real quick, and those of us that are familiar with the FRISC program, which is probably most of us, we know that you're really very school-based and education-oriented. And as we look for ways to streamline and thin down the cabinet to make them more efficient, would your program fit within the workforce development, education, and labor cabinet?
So, would it fit, was your question?
Yes.
Maybe. I think we would do great work if you put us in transportation, right? Like, I think we would do great work anywhere. I think when you look at the mission and the purpose of the program, and we really hone in on non-academic, non-cognitive learning barriers, I know that was part of the reason that it's in the cabinet in the first place. The expertise, the services, the support that is needed that really fit into that non-cognitive, non-academic, line really does live at the Cabinet for Health and Family Services. I've never worked at the Kentucky Department of Education, so I can only speak to my experience, but I think that I know that we are sharing information with our families around Medicaid, like unwinding. We're sharing information with FRIS about the unwinding right now. We're making sure that they have a basic understanding of that. I can give you lots and lots of examples. I know you didn't ask for all that. So could we do it? I think we could do great work in a lot of different places. I think when you look at it's specifically non-academic is what we do. And so that kind of makes it difficult to be in an academic setting and at KDE, administered by that.
You made reference that 4 years ago you put together these measurements of success, and
Yes, sir.
I remember one of my first committee meetings back in 2017 as we're preparing for the budget. I asked that very question: is how do you determine success? And at that time, one of the answers was, well, we serve like 100,000 kids. Well, that's not a measure of success. Just like, having 1.6 million people on Medicaid is not a measure of success either. It's a barometer of, I think, the socioeconomic status of our state. So I really appreciate that you took that message to heart. And you told me you were working on these success measures. But the things you shared with us today, predominantly things that are truly black and white, are educational specific, which they should be, because that's what the program was developed for in the beginning. And that's why I yield more towards being part of education and workforce development, because we've always got to be able to make sure we're impacting education for these people, because that's the only way we improve our state. But I think it's the same with AmeriCorps. Great programs that you all do, but for what you told me, there's more of a workforce development component in this than possibly anything other than providing services to the community that are certainly needed. So I think that's a discussion that we're going to have a little bit more, is where is the best fit for this? And it's not to make people's lives more difficult or challenging, just where's the best place and what's the best utilization of services. And so any other questions, comments? If not, greatly thank your presentation. Yes, Secretary Freelander.
So please don't take my good news stories away. But the other thing I want to point out, and so you all set this agenda and had the groups up here that you had. Dr. Stack talked about some of the long arc of programs. I want to point something out to you all. I think when I began to testify the very first time, I let you know I was appointed under the by Governor Patton, served completely the term under Governor Fletcher, and then served under, as our present governor likes me to call him, Bashir the Elder. The three of folks you had up here, Commissioner Morris, Joe Bringardner, Melissa Goins, I hired them under Bashir the Elder. They served the entire term under Governor Bevin, and they're still here under Bashir the Younger. So I say that to lift up that some of these positions transcend politics. That what folks do is just they're trying to do the work of the Commonwealth. And that's what I hope I inspire. That's what I hope they inspire. I hope you all appreciate that. But you just happen to pick three folks that span that. And so I felt like I wanted to point that out for what it's worth.
Well, I think it's interesting when something goes well, you'll take credit for that one, but then you do a Pontius Pilate on those things over. So I've seen your pattern here, but I think I speak on behalf of the entire committee is we truly appreciate the work that you folks do and know your passion, your commitment, and that's everyone who's presented. Again, the mission of this task force has never been to have a gotcha or somebody's doing something wrong. It's how can we do it better, more efficiently. And, one of the things that we've been requested to consider is hearing from providers, because they're a customer, from employees. And again, not the micromanagement, the cabinet, but employees are the rank and file. They've got some great ideas and may have some great concerns. And then there's the general public, consumers. But with only 5 months to do this work, it's virtually impossible. I think one of our recommendations will probably be that this needs to be a multi-year commitment, 3-4 years. And as we get into this, if we get approval for that, the next session, we may invite people to provide testimony that give us their impressions, because, people's perception is their reality. and we want them to have the best perception in the world as what this cabinet is capable of doing. And we want this to be a partnership with legislature and with you folks, and I'll assure you that it will be. But again, we're in the very tail end of this thing, and we've got to wrap up our work. But I appreciate the testimony, and we'll see where we go from here. But it's been a real education for me personally. I think all of our committee members, we really appreciate that and wish we could do more of it. But I appreciate y'all's testimony today. Everyone that's here and presented, you done an excellent job, and we appreciate it greatly.
Thank you.
Thank you for serving the Commonwealth. Our next meeting is November 2nd at 3 p.m. So the agenda will follow. Thank you all.